next up is Doug Zatzick, who is a professor of psychiatry here at Harborview.
Well, thank you. And Megan and Andy, thanks for inviting me out for this knowledge exchange. It's really interesting and fascinating, stimulating to get everybody's kind of input, especially from an emergency department perspective. That is the second slide. Let's see if I can figure this out. Back. And let's see, do we have a pointer here? We do. Good. Okay. There. So I will be bringing to the knowledge exchange a couple of decades of research from the acute care medical trauma center perspective. So I'm a psychiatrist. I work up at Harborview in the ED and on the trauma wards as a consultation liaison psychiatrist. And just multiple public funding sources, nothing else to declare. Great, incredible group of collaborators over the past decade or so at UW Harborview. So what I'd like to start out with is sort of, what we want to do is get to questions and knowledge exchange. So maybe about 20 minutes or so, just giving you a brief overview of our research program and sort of the paradigms that inform what we're up to. So the first thing, kind of the 2000 very high view, Mount Rainier view. Clinical epidemiologic methods is something we've really honed in on at trauma centers, and in particular this notion of population impact. So while we're focused on screening and brief intervention treatment effects, there's another component of this, which is reach, which is what Gail is getting to in terms of computer technology and easy rollout. So population impact derived from clinical epidemiologic methods, okay? And then the multiple comorbidities, that's what we'll be talking about. Not just drug use problems, not just alcohol use problems, not just violence risk behaviors, not just PTSD, but suicide, depression, somatic symptom amplification. These are all common comorbidities in our acute care medical emergency department and trauma center patients. And it's a very hard constellation to target incredible heterogeneity, not to even go into the heterogeneity of disease presentations. I'm lucky, I just focus on injury, but you guys, COPD exacerbations, HIV, so it's really tricky in the ED setting, okay? Then we'll look at some studies that basically I think establish the effectiveness, implementation, potential of alcohol SBI at trauma centers for injured patients. And from that, we'll build stepped collaborative care models. We'll take as our keystone alcohol SBI, which Gail's thinking it works. We think it works at trauma centers. Hopefully Rich Sage thinks it works. Hopefully Rebecca, hopefully the opinion leaders around the country think it works. And then we're going to build a stepped care model which moves to population-level screening and simultaneous patient-centered engagement through alcohol SBI to stepped-up care for PTSD, depression, suicide, somatic symptom amplifications. And these will involve referrals, but at least a model is out there that remains to be implemented. And finally, I think really important for this knowledge exchange is consideration of policy. We've been incredibly successful in trauma care systems for, targeting policy for comorbidities. It turns out that now before we ever do a clinical trial, we're working with the American College of Surgeons for nationwide policy. We've, the furlough willing, the gold book, the resources book. I don't know if people know these books. Those of you who work in trauma centers probably do. But basically, we're extending, based on some of the data I'm going to show you, the data that Gail has shown you, a mandate for screening and intervention at trauma centers from level 1s. Now, both level 1s and level 2s will have to screen and intervene. And with about 95% certainty, there will be guideline level recommendations for PTSD screening, intervention, and referral, and for drug use problems, screening, brief intervention, and referral. And I hope that soon the furlough's over and the gold book comes out and I'm not wrong. But I think that's all going to take place. So that's the overview. Now, population impact and clinical epidemiology. So clinical epidemiology is a science of understanding events in individual patients by looking at events in populations of patients. And we're really fortunate in trauma centers, and I think that there's tremendous potential in the EDs for this also. We have registries, complete censuses of all injured patients. So we can ask kind of key questions about, we do a clinical trial, we can ask, gosh, we know all these people were admitted during the time frame of the trial. What percentage of these people actually got recruited into the trial? So treatment effects are important for screening and brief intervention, but we can also fastidiously look at breadth of applicability and reach. And the combination, this is actually an epidemiologic fact that one of our collaborators, Tom Kepsel, has sort of proven in this paper, that there's this notion of population impact, which combines reach and treatment effects. And this is really what I think in acute care medical emergency department and trauma center settings we need to go after. Okay. So This is a paper from an NIH Roundtable. Knox was there. Gail took the lead on this. I think I'm the last author because I did nothing. And Gail was nice enough to put me on the paper. It could be alphabetical also. But basically, we got together in the chapel at NIH and we talked about drug use problems from the NIDA perspective, from NIAAA, alcohol use, from NIMH, PTSD, violence risk behaviors. All these comorbidities were sort of talked about. And at trauma centers, over 50% lifetime drug and alcohol use problem comorbidity. 20 to 40% of injured trauma survivors at trauma centers have high PTSD and depression. At Harborview, we've done a number of studies of this and randomly approached injured trauma survivors. It's basically a psych ward. And I tell this to Ron Mayer and Sue Stern, the heads of the ED and the trauma service. You're running a psych ward. Now, how do we want to deal with this, right? So basically, between 70 to 80% comorbidity of substance and mental health problems, okay? So this is the model. Let's spend a minute on this. I don't know, this screen or this screen. You guys tell me. So basically, where we're heading, and there's implementation. You get the change to Epic. You finally get your IT programmers to tune into your automated screen, and then you change your computer delivery system, and it's gone. And Chris Dunn can talk about the problems with this in his AIS screening. But basically, the model is population-level screening and engagement, patient-centered engagement. We'll talk a little bit about that. That's step one. Population level, maybe EMR screening, and then engaging patients around their primary concerns. There's been a lot of talk at lunch, and Kavita had a patient with low back pain, and we'll talk about that, okay? Then there's harm reduction. Now, this is motivational interviewing based. This is a generic strategy. We know it works for alcohol SBI. It might work for drug use problems. Dr. Cunningham's group has shown it works for violence risk behaviors. So step two is harm reduction using MI-based principles, okay? And then step three, the crowning glory, is evidence-based treatment for mental health problems like PTSD, depression, suicide, somatic symptom amplification. And this is the mainstay of this is SSRI, antidepressants, and psychotherapy. Now, at the trauma center, we have days, weeks, and maybe even months. You guys in the ED have hours, days, and so there needs to be translation there, but we're hearing this in the care coordination discussions, okay? So let's just take a step back. We're going to do a little bit on alcohol SBI. I just want people to, I want this to be a bedrock, because I believe in this, and I think there are going to be a number of perhaps negative studies, NIDA studies on SBIRT for drugs, and we want to just hold in mind that this technique, SBIRT, works for alcohol SBI, okay? This is based on the idea of a teachable moment. An injury severe enough that you're drinking and you're driving and you have someone, an expert like Chris Dunn, come to you and you spend a half hour, and the notion is that bubbles up on your own is that this was not the right thing to do and you're going to abstain. So, or at least reduce harm. This is a study by Chris. You'll see a few slides like this. Basically, x-axis is months post-injury, and then y-axis is severity of alcohol use symptoms. This is the dip. Dunn's dip, let's call it. Basically, this is pre-injury drinking, and then this could be the teachable moment. This could be you're in a sniff and you can't get a Budweiser, but nevertheless, your drinking seems to naturalistically go up over the course of the year after the injury. This is a prospective cohort study, no intervention. So, first SBI study done from Harborview. Chris is the interventionist. Larry Gentilello is the first author. Okay, 1999, Annals of Surgery. Basically, 600 patients, 300 get 30 minutes by the bedside with Chris doing MI, and 300 get usual care. You see the dip and recurrence, same thing we saw in the cohort study. Chris's intervention, dip, and a maintenance of diminished drinking over the course of the year. Most interesting from a trauma surgical perspective, because many of our hard-headed surgeons don't believe in patient self-report, is there's automated data. We talked a little bit about this during the Spokane presentation. The CHARS data system in the state of Washington accrues data on your intent to treat sample without ever having to do follow-up, okay? So basically, there was a 50% reduction in recurrent injury admissions associated with Chris's intervention, which was pretty impressive, okay? Chris got a job, he still has it, full-time FTE at Harborview to do alcohol screening and brief intervention. We did a follow-up study, effectiveness trial. Now, this is stepped collaborative care. Okay, so basically, we're now going for multiple comorbidities at our trauma center. The main target for this is PTSD and depression, but there's a substantial minority of patients, too many in the intervention and too few in the controls, but no matter, effective intervention. I can explain this if people are interested. But basically, Chris trains a social worker just out of MSW school, an expert interventionist. She got a lot of training, who delivers the bedside MI and then booster sessions. You're in orthopedics. You're in the cast room. You're getting your cast off. There's a lot of vibration. Now I need a drink, okay? That's 2-3 weeks after your initial bedside intervention. Well, let's talk about that. You find some white noise, which is easy in a cast room, and you do your second MI booster, 10-15 minutes, okay? What do we see there? Same 50% reduction in recurrent injury admissions. Only 120 patients in this trial, so the confidence interval runs through 1.0. But nevertheless, one of our trauma surgeons, Jerry Jerkovich, who's now at Denver, was the vice chair of the American College of Surgeons Committee on Trauma, and he pushed through a mandate for alcohol screening. Okay, this is what's been upgraded now. So basically, level 1 and 2 trauma centers would have to screen for alcohol, and level 1s would have to have a mechanism to provide an intervention. Now, this is going to change, and level 2s will also have to. Okay, so I warned Ed Bernstein about this slide, but there was reasonable doubt. What were we ready to roll out based on these few studies, and there were negative studies out there in 2005, 2006, 2007? Were we really ready to take to scale alcohol screening and brief intervention? There were some questions. So we did a nationwide study within trauma care systems. This is Chris's slide, great logo. This is a schematic. Just as you have denominators at the patient level, there's always a denominator. You just have to be able to measure it. There are 1054 trauma centers in the United States, 204 level 1s. What did we do? We took trauma centers and we characterized them. Gail and Yale is an innovator site. She's got NIH funding. She's teaching up the wazoo. They don't need any help to implement SBI. Okay, you have folks, trauma surgeons in the Deep South and elsewhere in the country. They don't see this as part of their job. They're not going to do anything. Okay, but there's a middle majority of trauma centers that are willing to do this. They just need the know-how. So we randomized 20 of those trauma centers. 10 got Chris done, 1-day visit, and then 4 feedback and coaching sessions over a 6-month period. I did a brief organizational intervention to help people develop their SBI services. 10 trauma centers get care as usual. Okay. What do we hypothesize? And Chris will tell you about the better trained providers. He actually hit a home run. I had an MI protoplasm like, oh my gosh, middle of the country, trauma nurse offered up for training. This is not going to work. They haven't seen mental health in 2 decades. But Chris worked his magic, and you'll see that in a little bit. The 10 control sites, then we thought the 10 intervention sites would have better alcohol use problem outcomes. And this is our result. What is this? Again, we have months post-injury. Let's back up. We have months post-injury. Okay, we basically have an 8% reduction. The audit is the main outcome measure, no matter how you cut it, continuous or dichotomous. This is dichotomous at-risk drinking. 8% reduction in at-risk drinking in the patients at the 10 sites who got the organizational and MI workshop training. Okay. So let's just look, because this is in the Alvin Feinstein Yale University sensibility kind of MD-MPH tradition. Let's just look now. Okay, so this is the initial efficacy study. Okay, DIP recurrence in the control group, DIP maintenance of diminished drinking. Okay, this is the effectiveness trial with boosters. Okay, and this is the nationwide rollout. Very similar patterns. Okay, but an attenuation of treatment effects as you would expect in the implementation trial, in the nationwide rollout, but still same pattern of response. So for us, we're okay with the college requiring now level 2s based on this and data that Gail was presenting in other trials. There are negative trials, but we think we have a pretty firm bedrock in terms of SBI. So how much time has we?
Still have,
I'm talking too fast,
no,
but you guys can ask questions. Okay. So Harborview. So let's take some case studies now in terms of thinking about comorbidities. Let's go into the weeds in terms of like how to deal with these really complicated patients. And a couple times now we've talked about patient-centered care, and I really think this is where the hope is for much of this, okay? That and sort of automation of that which can be automated. So let's take, Andy was talking about going down to Pike Place Market. You want to go west, okay? You go a little bit sort of south and you get to Harborview. You go a little bit more south and east and you get to the Central District. You don't want to wander over there. It's a classic sort of low-income, incredibly diverse inner-city neighborhood in Seattle. So young adolescent comes into Harborview a few years back, 15-year-old. She's knifed in the face, left cranial nerve is nicked, not severed, okay, and she's blood alcohol positive, okay? So we've been doing for the past decade these patient-centered sort of investigations, really honing in okay, on an essential sort of set of questions that we feel are patient-centered and simultaneously allow empathic exploration and assessment. And they can't be broken. We've used them in Haiti, post-disaster, so we're going to get to those. But here's our basic model now. We've done our screening. Now we're going to engage, and we're going to support someone in a time-efficient way, okay? Then we're going to move to harm reduction, and then the crowning glory, if we still have someone with us, we're going to do symptoms and function, and PTSD, and depression, and suicide. Okay, so post-traumatic support by the bedside. Social worker, ED, doc, psychiatrist, you tell me. Of all the things that have happened to you since your injury, what concerns you the most? Okay, so for Kavita's patient, her patient 1, low back pain, okay? Of all the things that have happened to you since your back pain got worse, what's most concerning to you? Well, I can't get to work. I mean, I really don't need the opiates. I just need a slip from you to let me off for 3 days. Or, you know, COPD, of all the things that have happened to you since your breathing problems, your exacerbation, what's concerning you the most, okay? So, and you can ask this. We've studied this. It doesn't hurt people. It doesn't take out PTSD. It doesn't take out alcohol, but it allows empathic therapeutic alliance and engagement early on wherever you are, gurney, trauma bed. So that's what we're going to do with this 15-year-old. And of everything that's happened to you since your injury, what concerns you the most? So on the gurney, she's actually on a trauma ward. My smile might not be back no more, and my face might be scarred for life. Okay, perfectly sensible for a 15-year-old who's been knifed. Okay, maybe a gang-related event, maybe alcohol involved, all sorts of other things. But disfigurement is her primary concern. Okay, so we're going to go after that. We're going to give her a care manager. We're going to pretend we can get the resources for an MSW that can run out of the ED and run to ENT clinic in 2 weeks. Okay, and we're going to ask her these same questions. Let's just give ourselves that. Okay, 2 to 4 weeks. Busy ENT resident. We've got our social worker in there, though, who's asked the patient again, of everything that's happened to you now 2 weeks later since your injury, what concerns you the most? My face being back the way it used to be, I think they cut a nerve, so they said it takes 4 to 6 months or so for my smile to come back or not. Okay. Anything else bothering you today? Well, I'm kind of traumatized because, like, when it happened, I thought I was going to die and stuff. So I don't know, basically just hanging and stuff. It was just a total shock, I guess. So I don't know how this lines up with DSM-4, DSM-5, but this is PTSD, right? This is sort of shock, arousal, okay? And everything we know, okay, so we're in our stepped care. We've sort of engaged her. We're in ENT clinic, okay? We know there's harm reduction issues. There's alcohol. There's violence risk behaviors. This may have been gang-related. I don't know what you guys call it, you know, at Harborview, the happy pack. You know, this patient is going to bug that ENT resident about her disfigurement. That's going to be a nuisance. There's almost an instinctive desire to give maybe too many opiate pain meds. That's our happy pack. So on top of her alcohol problem, now you've got this anxiety or depression. You know, I think the gentleman from Wisconsin was talking about a 17-year-old with depression. But you've got these sort of symptoms, anxiety, depression, other mental health symptoms that are driving the potential towards addiction. Okay, and this is what makes this complicated. Once you get these comorbidities, I don't know if it's just going to be a computer program or the best avatar. You know, the DoD is developing these incredible avatars. I don't know. It may always have to be a person. Okay, but we'll see. All right, and then so this is where in step 2 and step 3 there's sort of an interchange and an interface, and this requires a more skilled provider with more time. Okay. So we know there's an evidence base for the simultaneous targeting of step 2, and Dr. Cunningham will probably talk about this. But this is Dr. Walton and Dr. Cunningham and their Michigan group. We've done a series of trials now for step 3, and this is recently published in the Annals of Surgery, March 2013. Basically, this model, I think we'll just cruise through this. This is basically showing you improvements in PTSD. Interestingly, here at 6 months, this PTSD difference is associated with 5 points on the SF-36 physical component scale. So really a chronic disease. If you take out PTSD, if you target that intensively, and the reason we don't have a mandate is this took us 10 hours over the course of the year, so the surgeon said too long. And we said too long also, we can't do that. So we're working on shortening this up. But basically, both PTSD and physical function move together in these trials. So stay tuned in the Gold Book for a best practice guideline recommendation for PTSD screening, intervention, and referral from the American College of Surgeons. Where do we go? We're not like Laura Ducharme at NIDA, and you know, we do read the 60 articles on implementation science, but we basically are actors in a system. I'm on, you know, the Harborview wards all October in the ED and the trauma wards. give me some time. This is going to be complicated. Forget the fishing expedition. Forget the questionnaires. I want to push a button and get an EMR screen that does the whole hospital, that first swath. From a population impact perspective, actually, we can show this to you mathematically. Everything you lose in terms of your screening diagnostics, you gain in terms of reach, okay? What's the first thing we all know goes out the window if, we got gurneys lined up outside, the ED, or, too many patients to peel off the ceiling because they're psychotic. We don't ask those screening questions, right? For alcohol, now you can want alcohol, drugs, PTSD, depression. No way. So, automated EMR screen, okay? Stay tuned, best practice guideline for drug screening, intervention, referral. And as just mentioned, Dr. Whiteside, who trained with Dr. Cunningham, and now we've inherited her, else Dr. Cunningham's going to try and recruit her back, no doubt, but the winter in Michigan is just horrible out here. So, even though we have rain. So she now is going to replicate our PTSD, automated PTSD screening algorithm, and we're going to try and develop that for prescription opiates. All right. Drop by if you have a little bit of spare time. We're all up at Harborview, and we'll take some questions. So,
Thank you, Doug.
all right. No questions.
There's got to be some questions.
Caleb,
Okay.
you must have a question. No. See, I did talk too fast. That's okay. We can let we can let Dr.
I was say, so I have one question, Doug.
Sure.
So on an everyday basis in the ED, going back to our friend from Yakima, who I apologize, I don't remember your name, but on an everyday basis for folks in the ED who don't have an MSW, or maybe have trouble kind of finding a psychiatrist to refer to, what do you kind of suggest for them, recognizing that mental health problems are often coexistent, that many of our patients have dual diagnoses?
So yeah, I mean, I think we heard a little bit, and maybe the folks in Tri-Cities or the folks in North Carolina can talk a little bit about this, because what you heard was an effort to coordinate care before the patients come in. I mean, maybe it's like a community-based sort of coalition for high-utilizing patients. I mean, that is a fantastic idea. We're developing clinical decision support tools that have automated referral sources, so you could have a zip code, and then you know where to send people, so your ED social worker doesn't have to do it, and it's all in one tool. I mean, that's our vision, is one-stop decision support, automated screen. The intervention we think is going to have to be a human intervention to deal with this level of complexity. But then referrals are part of the clinical decision support tool. And we just got funded by PCORI to do this. They're interested in patient-centered care. We've made a deal with the trauma surgeons. They're going to sit down with PCORI. We're going to do a randomized trial. And if we can get movement on this concern item, then we'll write into the American College of Surgeons guideline in our computerized decision support tool these patient-centered pieces also. So what am I saying? I'm saying community networking is great, but then if you can begin to work on computerized decision support, I think that's where the gold is for the next decade. Other questions? I talked too fast. That's okay.
No, you don't. It's
Okay,
great.
okay.
All right.